Have an interesting topic combining and choosing glaucoma and cataract surgeries. And I am believer of the dictum of American Academy of Ophthalmology, which was published in INET magazine, that trabeculectomy is the king. There is a lot of discussion going on, but trabeculectomy is acting as if like sphygmomanometer. All the digital manometers are standardized against sphygmomanometers. So all the present day glaucoma devices ultimately are compared and standardized against a successful trabeculectomy. So that's why I always propagate that, like phaco surgery, try to customize your trab. It is a maybe half-century old procedure, or sometimes the proponents of modern glaucoma shunts and devices say that the people are still doing 30 years old procedure. That's right, but try to customize it. Try to find out your own way. And if you customize it and repeat it in your own manner, that will help to minimize the complications and go for better results. So जलते हुए परवानों पे हैरान हुआ कर. Don't be surprised by burning moths. जलते हुए परवानों पे हैरान हुआ कर. You मेरी मोहब्बत से परेशान हुआ कर. And don't be bothered with my love as well. कुर्बान पतंगों की तरह होने दे हमको. Either you let me sacrifice myself like a moth, या शम्मा की मानंद you फरोजाना हुआ कर, or don't lighten yourself up like a beautiful candle flame. So we come to our topic. The discussion plan is, first we will be just discussing, as I have already mentioned, treatment goals and choices. And then we will see the role of standalone phaco cataract surgery in open angle glaucoma and chronic angle clovial glaucoma. And then we will be just going through standalone trabeculectomy. And then we will have a look on the problems associated with post-trabeculectomy phaco surgery. And lastly, second to the last section, we will be discussing phaco-trab. And finally, we will be summarizing our discussion. And at the beginning of every section, I'll continue reciting my poetry. So the goals of the treatment are, as always, improve the visual acuity, reach the target IOP, try to make the patient free from drugs, and preserve the visual field and the nerve fiber layer thickness as much as possible. The choices of glaucoma surgery we have already seen depends on the degree of the visual field changes and the nerve damage. What is the mechanism of glaucoma? What's the condition of the or status of the angle? And what's the visual potential of the patient? And the risk-benefit ratio of the expected complications and of the disease. And is there a cataract? That's my topic actually, that there is an element of the cataract with diagnosis of mild, moderate or severe glaucoma. And then discussion with the patient is very key point here, because whatever you do, whichever procedure you opt for glaucoma surgery, you have to explain the patient very well the possibility of need of secondary and tertiary and other interventions in the post-op period. And as we have seen through all the discussions of lasers and other things, that there is no final procedure for glaucoma like phaco surgery yet. So we have to keep that thing clear to the patient that you need a continuous follow-up and you may need reintroduction of drops or some suture lysis or needling or whatever. So trabeculectomy, cataract surgery and combined surgery. So trabeculectomy is the king. So better keep this beautiful classical picture in your mind whenever you are going to opt for this king of the procedures, that is trabeculectomy. Large area, try to direct the flow posteriorly and may use adjustable sutures or be ready for suture lysis in post-op period. Large scleral flap and a good iridectomy. So we go to our section 2, that is standalone phaco cataract surgery. मुझसे चुरा ली है नजर मिलने से पहले. You have taken your eyes away before I could read anything. इस कदर तो मोहतात मेरी जाना हुआ कर. You should not be that careful while beating your eyes with mine. इस इश्क जज्बे से तेरा हुस्न अमर है, यूं हमसे खफा शहर निगारा ना हुआ कर. Cataract extraction alone it has been now established that it decreases 2 to 4 millimeters of IOP on long-term basis. And there are 2 or 3 hypotheses behind this theory. One is that it gives rise to the level of cytokines in the aqueous humor is changed, which gives rise to ultimately changes in the extracellular matrix and the meshwork and decreases the pressure in open angle glaucoma. And in narrow angle glaucoma, naturally it opens up the angle, and as we were discussing LTP and the organ laser trabeculoplasty, so automatically the cataract surgery alone can give rise to opening of the angle, and it can change the quality of life of the patient both in glaucoma and cataract management. So IOP lowering effect, as you can see, we have already discussed remodeling of the extracellular matrix and the change in the chamber angle. The facts are well documented. तेरा सितम हमको करम लगता है जाना, तू जोरो जफा करके पशीमाना हुआ कर. जब दिल ही नहीं बस में तो फिर नजर कहाँ हो. When my heart is not in my control, how can I control my eyes? गुस्ताख निगाही पे यूं नाला ना हुआ कर. So please don't be angry by myself looking at you in that way. So standalone trabeculectomy is a good procedure, but we all know that it will give rise to development of cataract, synecdoche, and so many other issues. The cons are it is cataractogenous, and the complication rate, hypotony, failure, revision, all the things we know. But it can be sight saving in some patients. So we just go through the standalone trabeculectomy here.
During trabeculectomy, what I do is I routinely injection mitomycin C pre-op into the subconjunctival space, 0.02%. So I don't use intraoperative mitomycin C sponges anymore for last few years. And then a fornix-based, after raising a fornix-based conjunctival flap, a regular half-thickness scleral flap to or 1/3 thickness scleral flap is raised with crescent blade. And once the flap is dissected, I use a traction suture to expose the site for deep sclerotomy to avoid handling with the hands of the assistant, because I'm afraid sometimes they just tear the flap and hand it over to you, smiling and saying sorry. So I just apply a very gentle traction suture and I cover the corneal surface with viscoelastic material. 2 knots are applied, and then the deep sclerotomy site is beautifully exposed without any external help, and 11-0 blade is being used to dissect deep sclerotomy, straddling the limbus, and in a very gentle manner, a quadrangle of deep sclerotomy is dissected out, and finally cut and remove with venal scissor. And as soon as the scleral bed is removed, a little cautery, and then iridectomy is performed, and at the same time the suture is cut and the flap is reposed. And generally I perform 2 sutures to the partial thickness scleral flap on both sides, and I take a long bite generally so that I am able to bury the sutures on both the sides. So 2 interrupted sutures on the 2 corners of scleral flap, the knots are buried, and the final step comes into play, and that is applying the suture knots to the fornix-based conjunctival flap and its reapproximation. For that, I take deep limbal bites on the corneal side and a good healthy bite on the conjunctiva on both sides, assuring that it is snugly and tautly approximated with the de-epithelialized limbal cornea. So I make these sutures so tight that the folds may appear in the cornea at that very time, because this is a crucial step in success or failure of the trab. These 2 sutures, if applied well with deep bites, will help to make sure that there is no leakage post-operatively. And I no more use any in-between sutures. And we will come to that later on. Another key is that my deep scleral flap sutures are also very tight generally, because I want to see my AC formed next day. So this is where I close the trab and approximate it well.
And then we go to post-trabeculectomy phaco cataract surgery. As you see, there are posterior synecdoche and the cataract formation is here. It is about 1.5 years post-trabeculectomy. It was a case of refractory glaucoma which I performed TRAB MMC. And now we are planning the cataract surgery here. So I am using a temporal incision. Alhamdulillah, I have this beauty of being ambidextrous. I do right eye phaco with my right hand and left eye phaco with my left hand. So I enjoy a lot of freedom while placing the cuts and handling the phaco probe.
As I mentioned earlier, there are posterior synecdoche and a pupillary membrane. So we have injected injection adrenaline, and now we are teasing the pupillary margin to remove the pupillary membrane all around. Viscoelastic is judiciously being injected at the same time, and then the Utratra's forceps comes into the picture, and we are able to just pull the papillary membrane away. And from a side port incision, I make sure that the iris is not only free of synecdoche at the pupil margin, but stroma of the iris is also not adherent to the lens capsule. And the pupil dilation was not enough, so we loaded the OSS ring into its cartridge and decided to dilate the pupil with the help of disposable OSS ring. We injected it, though it was broken, but still it served the purpose. We engaged the iris into its margins and were able to perform a good capsular axis with a little rip in the infratemporal quadrant, but still it was completed successfully. And after completion of the needle assisted capsular axis, Again, Utrata forceps was used. I just removed the OSS ring because I found it obstructing because it was broken on one side. And hydrodissection has been performed and a gentle phaco has been there. And we were able to complete it successfully. The second instrument is as usually active, and simple cannula is being used to aspirate the soft cortical matter from all around. And the capsule is intact. And here comes the Rayner Superflex intraocular lens successfully injected into the bag. And the trailing haptic is also placed in the bag. So lens is positioned well at 3 and 9 o'clock position. The wound is hydrated and we complete the surgery. So there were problems because it was a post-trabeculectomy phaco. So you see, the trab does help to control the IUP well, but induces so many issues at the same time, which make the even cataract surgery more challenging and difficult.
इंसान है खता हमसे कोई होगी यूं बरहम व नाराज़ व सितमराना हुआ कर. So I request Dr. Mabnaz, यूं बरहम व नाराज़ व सितमराना हुआ कर, अफसाना मोहब्बत का ना खुल जाए जहाँ पर, मजलिस जाना में गज़ल खाना हुआ कर. कहते हैं साइंटिफिक सेशन में पोएट्री करता है, तो मजलिस जाना में गज़ल खाना हुआ कर. Dr. Mazhry, don't recite your poems in scientific sessions of ophthalmology. मजलिस जाना में गज़ल खाना हुआ कर.
So we need to combine the procedures. When a patient has cataract and potential or a defined established glaucoma, the surgeon has to make a couple of key decisions. First, does the patient really need both surgeries? Second, both the surgeries are called for. When do we need to combine is when the cataract is really significant and the patient, in our opinion, has moderate to severe glaucoma and is on multiple drugs. If in case of a mild to moderate glaucoma, only single drug, cataract surgery alone may be beneficial as we have previously discussed. But if the patient is using 2 or 3 kind of drops and there are signs of toxicity and as well as the glaucoma is severe and not enoughly controlled, and at the same time there is a diagnosis of cataract, then the patient may be a beneficiary of combining the procedures. So there is a visually significant cataract as well as moderate to severe glaucoma in this case, and we have planned a combined Phaco-Trab procedure. And as in the first slide where we explained a regular trab, I am injecting the injection mitomycin 3.02% with the 27 gauge band needle into the subconjunctival space at the site where I am going to, where my bleb is supposed to be. And generally this injection is diffuse and on a wide space in nature. As I am going to raise the fornix-based flap, so diffuse subconjunctival injection at the trap site is infiltrated. And as we have already discussed, I always prefer in my practice 2 separate sites. The trap is performed superiorly and the phaco I have planned temporarily. And If you are able to teach your non-dominant hand well, then this shifting of the positions, sitting on 12 o'clock position comes quite easy. And as you can see, in the case of right eye, I shall be able to perform a temporal phaco sitting on the head side. And for the left eye, I shall be, after training my non-dominant hand that is left, I am able to perform the left eye phaco and incisions with the left hand. The two side ports are fashioned and injection adrenaline has been injected into the anterior chamber, and the pupil is relatively better dilated now. The 2.75 millimeter knife was used to fashion an incision at the temporal side, and cystitome needle assisted capsulorhexis has been performed successfully, and then the phaco is underway, and divide and conquer technique. By chopping the segments of the nucleus, we have cleared the nucleus, and the blend matter has been aspirated. The bag is fully inflated with the viscoelastic, and the intraocular lens has been injected into the bag. And that's a quite routine procedure. Now the phaco and IUL implantation process is completed, and we have directed our attention to the trab site. The fornix-based scleral flap, the conjunctival flap has been dissected, and the crescent knife is being used to raise the partial thickness scleral flap. And similarly, I am applying this gentle traction suture to expose the deep sclerotomy site, and 11-0 blade is being used to dissect deep sclerotomy, straddling the limbus. Here I am using actually 15-degree blade, and that's a better option as compared to 11-0 blade. And one needs to be gentle here. We have to dissect it clean without damaging the underlying iris and uveal tissue. The venous scissor is used to dissect the window off, and at the same time the iridectomy is performed, and in the single go the traction suture is cut, the scleral flap is released, and as we have seen previously, I have applied 2 sutures on the corners of that scleral flap, and the knots have been buried. Now our conjunctival closure is underway, and I have taken a deep bite from the limbal cornea, and a taut conjunctival approximation is aimed against the de-epithelialized corneal limbus. So both the sutures are there, the conjunctiva is snugly and tightly approximated, and the knots are buried, the viscoelastic is cleared, and we are there with our combined procedure of phaco-trabeculectomy. This is a final look.
So, cataract with well-controlled open-angle glaucoma, you can go for only cataract surgery with only 1 or 2 drops. So, cataract with chronic angle closure glaucoma, cataract surgery may serve the purpose. Reevaluate your patient, keep him under observation. After cataract surgery, you may not need any other procedure. It's quite possible because the cataract surgery alone will deepen the chamber angle. If the cataract is with uncontrolled open angle glaucoma and moderate to severe damage, then you can go for Phaco-Trab with MMC. And if there is a cataract with advanced glaucoma, now there is a little kind of controversy. Because Trab alone will control the IOP better than Phaco-Trab. Many studies show. But I will prefer still, in presence of cataract, the Phaco-Trab. So we have already summarized our discussion. Pearls are choose between the procedures I have mentioned, then use the separate sites while combining the procedures, and don't let your anterior chamber get shallow. That's the key to success. While combining or performing trab, apply tight sutures with slip knots. You may remove it at your will. or be ready for suture lysis, or be ready even for intervention with a needle. You can cut the sutures and be ready for even revision of the flap if needed. But don't let your chamber collapse. That's the key to success. That's where the complications will arise with choroidal effusions and hypotony. So, with permission of our respected chairman and everything, Professor Mabnaz, सादा दिली तेरी कहीं तुझको न दस ले, हर एक पे ऐ दिल यूं मेहरबाना हुआ कर अपनी ज़िया से तू जहानों को मुनव्वर, बस नाम कहीं मज़हर ताबाना हुआ कर. Thank you very much for your attention.